I'm Anastasia Jaegerman. This is part 2 of the Women Warriors series. I'm back with my guest, Erin McClintock from Nationwide. So we left off, we were talking about women's financials issues and the purchasing power in the life insurance industry. And part 2 today is talking about medical issues, specifically as it targets women. And Erin, welcome back. We're back for part 2.
Yeah, part 2. I'm excited for it.
So let's dive right into the typical subject, obviously, pregnancy issues. So we'll walk down memory lane once again. When I started underwriting, pregnancy was a high risk pregnancy was considered any female that was pregnant greater than the age of 32 years old. So imagine. So we've moved a lot in age. I'll let you continue. I'll let you piggyback on that one. And all the concerns that we had back in the, again, this dates me, late 80s, beginning of the 90s. And we could talk about, the third semesters, but I'm going ahead of the game now. Like, tell me what now you see in underwriting and what we now consider a high risk pregnancy, and who knew there was such a thing still existing after all this time?
I mean, I think it's even worse, the fact that, it's called a geriatric pregnancy.
Is that what it's called now?
It's like, yeah, it's and age 32. That's so, I mean, that's young, right? That's a really young age, especially when you're looking at how society has advanced since the 80s, where you're seeing a lot more women going to higher education and having a career and delaying in families. And we're starting to see that. When I started underwriting, like, high risk was age 35 and over was geriatric. And now you're looking in various, pockets where it's age 44, right? Even the American medical, the AMAs has pushed that back to being much older, just because there's a lot more women who are delaying starting families because they're putting career, they're getting settled, they're doing all the travel adventuring, eating avocado toast. Here's this, maybe they can't quite afford it in their 20s, but all of that stuff that's coming through from a societal standpoint, and just in all honesty, advancements in medical, right? There was this very alarming, and I even remember when I was younger and when I was, starting as an underwriter, there were a lot of women, female, like, underwriters who would get a little bit up in arms with women who said they had a planned cesarean. And they were like, a planned cesarean? That means that's high risk. That means there's a reason a doctor would
perhaps we should not take this risk right now.
Yeah.
We should maybe delay the process.
Postpone it. Or, you love this as a reinsurer, just toss it over the fence to a reinsurer.
Yeah. See what they do,
right? But it's, a lot of women do plan their C-sections. It's not a at dire need moment in pregnancy anymore. So there's that advancement in technology and medical that has absolutely impacted the way that we're seeing things from medical. And as we talked about in the first part of the podcast series, is once you get women in the door financially, you have to medically back up and being able to offer, and you can't always be postponing for something. Or even, like, let's just even talk about weight loss after pregnancy.
Right.
A lot of women gain weight. It happens.
You're
carrying another
human being.
And guess what? It doesn't drop off as quickly as we would love to hope. I mean, weight we gain even not pregnant, we would love to just instantly drop off at the snap of our fingers, and it doesn't. But even allowing women more time in the underwriting process to be able to shed that weight, it went from, like, you had to shed weight within the last 6 months. Now we're looking at 12 months. And we're giving a lot more opportunity to put women in preferred risk class, right? That they truly are meant to be in. Just because you're pregnant doesn't mean you can't be offerable. Right. But, we still have to pay attention to what's going on with pregnancy, right? There are some high risk, right?
There's some risk.
Preeclampsia.
Right.
We also have maternal mortality rates. Being in the United States, we're far advanced in medical, but we have a really dismal, embarrassing, could not believe it for a first world country, maternal mortality. It's like, on average, it's 23 deaths in like 100,000. But if you're looking at women of like Black women, it's significant. 49. It's even higher.
Yeah.
And so you're starting to look at kind of where's this happening?
Right.
Why is
and
it happening?
That access to hospital, because you mentioned a term that I was not familiar with, but hospital desert.
Yeah.
So is that like, what's the future of women's issues? Like, how will they tackle with the landscape that we're currently in? Like, maternal mortality in the U.S. should not be this high.
It shouldn't.
So, and we talked about also of women advocating and bringing doulas to help them in their pregnancy, which I'm not familiar with, but I thought that was a very interesting concept to bring forward.
I mean, it's so like, I think we talked about it in the first podcast series. I'm a childless cat lady, right?
Right.
So, this is really hard for me.
I don't have any children either.
I don't have a personal experience with this, but I can tell you, I have tons of female friends that have had birth and given birth, and they're not always listened to in the delivery room, right? Like, sometimes doctors have a tendency to listen to their partners more than the women who are going through this experience. And so by bringing in doulas, you're starting to see them a lot more in women of color who are bringing in doulas to help advocate and speak for them, and being able to help the nurses be able to say, like, look, this doesn't feel right. It's uncomfortable. How can we help? And really, you're starting to see these really good metrics of doulas being able to help with the stress, which is bringing down the blood pressure, right? So you're not going into that, preeclampsia, those situations that are there that are starting to get into those more comorbidities that we see that are associated to high risk pregnancies. And the interesting thing with hospital deserts, you're seeing this more. That's not just impacting pregnant women. It's during the pandemic, there were a lot of hospitals that couldn't continue funding, right? Because you had elective surgeries that could not be performed. And elective surgeries, such as cosmetics and things like that, those are profit building, right? If you look at it from a medical care perspective, not necessarily mortality, but they generated profit. So when these hospitals in small areas couldn't continue to thrive and remain open, we now have medical deserts. And could you imagine just being a woman pregnant and being, 100 miles away from your closest facility? Thankfully, there's a lot of non-for-profits that are out there, helping with all this maternal mortality, like all this maternal care, and helping with infant care as well, because there's a high infancy rate too. But, these are just little aspects that from a societal standpoint are part of our underwriting process. And, we always get to watch it from an actuarial lens, from a protective value, things like that. But we have to continue to watch to see where society's trending and taking us, especially as we're becoming more aggressive than what we had been previously since the 1980s when you went to age 32 to 44. I mean, that's a very wide difference.
Yes, definitely, which brings us to kind of segue into the medical aspect. When you said medical desert, also like for PAP exams, so that's a very important, preventative cervical cancer, uterine cancer aspect. And if you don't have the facilities nearby, I could easily see a woman skipping their pap smears for several years at a time. And which is not recommended at all. And, in the olden days, we had, the LEAP procedures for the SIN from 1 to 3, and then, laser. But now they've come up with, you and I were talking about this, and I don't know if it's out already. I think you told me it's out, but the self-PAP exam.
Yeah, so actually it was approved in the United States since starting September of 2024. In certain medical facilities, it's actually a self-PAP test. So there's a lot of, when you're looking at gynecological exams, there's a lot of women who've been sexually traumatized or been abused in ways, or they have just physical pain from the examination itself. So this test actually started in Europe. So I'm going to list these countries, and I think people are going to put on their shocked face. Ready? So Denmark, Netherlands, Sweden.
Shocker.
Right?
No. Being sarcastic.
Yeah, being sarcastic. All the sarcasm there. Our lovely friends down under, the Australians, and then the United States have joined in on utilizing the self-PAP test. And what it does is for HPV detection, it's actually using the walls and not scraping the cervix.
Inside. Okay. Interesting.
So it's using the walls, and it's actually just as effective in finding positive HPV. So when you were talking about in the past, we were looking at LEAP procedures and things like that. I remember when I first started underwriting, it was if you were HPV positive, you had to have 2 to 3 pap smears that were normal before we would offer to you. And if you think about that, that's it. Like some doctors, it's 3 months, 6 months. So it could be potentially up to a year to 18 months later to being able to be an offerable again. And that's with clearing it, right? And I think there's been just a lot more education around HPV as we've done a lot more medical studies where it, in some instances, it clears on its own.
Right.
So it's not as alarming and scary as it used to be. But the one thing that's coming out of, the self pap smear test that's going to be exciting for a lot of women is that this technology is going to get us to the place where it's going to be an at-home test. Could you imagine being at home?
Yes.
And being able to do this and send it off to a lab, and then it could be there. And I know all the underwriters listening are going to be like, is it going to be part of lab picture? Is it going to be part of your electronic medical
Are we
record?
going to get the data?
Are we going to get the data? And it's like, I don't know the answer to that. We just don't know at this point. I mean, I'm going to make an assumption, yes, because it feels like everything's in data format these days. But,
it'd be just an additional test that you would have like now when you have a mammogram and you go to your portal.
Exactly.
Because you'll have to send it to a lab.
Yeah,
so a lab will have to analyze it. You'll get it back. And then you'll have to have a record. And then there you go. It will be part of your medical data.
If it's abnormal, then you go back into your doctor. You start to have your conversations there. But, this is just an advancement more in women's health that is very much needed just because I don't know if many of you know this, but it wasn't until the 90s that women were actually brought in vaccination studies before they were rolled out. And
Which brings the HPV vaccine into play.
Right, brings the HPV vaccine into play. Definitely. And then that's when you start to see it widely rolled out a lot more. They've even upped the age. You can go up to age 40 now. It used to be age 30, and now you can go up to age 40 and still get it. So you're seeing that advancement, right? And just even the age groups that can qualify for the HPV vaccine.
And what we haven't talked about, and I know we won't spend too much time, but HPV and men. So it's possible that men have HPV, and we won't name any names because then I'll be cut off. In any case, we won't name any names. But like, how would we address HPV in men? Like, I'm sure that I don't think our underwriting manual does, but what would happen? I don't know. Big question mark.
I mean, it's a good question mark. It's even if it's going to be disclosed, right?
Right.
So are there, there could be, are there ways that some people in their interviews cap certain reproductive medical disclosures to certain genders? Right. So
Good
it's like,
point.
Would you ask all men if they had gestational diabetes? Probably not.
No.
Right?
Exactly.
You probably wouldn't do that. Would you ask all women if they had prostate cancer?
No.
So,
but HPV is a virus.
It's a virus that's applicable to all genders,
All
non-binary, however you identify yourself. So it's, it'd be a really great thing to see if there's, somebody who's with a vast amount of data, if they would do a study to see how much we see HPV positive in men. Because most men generally don't get tested for it. I mean, let's be honest, most men don't even go to the doctor.
Right. That's true.
Unless there's like some blatant symptom, kind of like the person that we're skirting around from a very celebratory place.
Yes.
That he had symptoms. So he went and found and got treated.
Discovered.
Right.
Yes.
And so, maybe as society's advancing on the women's front and having a lot more vocal conversations, maybe men will be able to start to feel more comfortable about talking about their HPV.
And I'm wondering, I know a particular couple in question, and she was going through some cancer treatment. It's kind of off topic a little bit, but she actually tested positive for HPV. And long story short is then they proceeded to test the husband, and the husband was positive for HPV. So you're like, okay, well, so where kind of originated from, or you suspect, or you hope, or whatever. That's another topic altogether.
I know, and even my doctor just was like, everybody's gonna have HPV. Like, it's just such a widespread virus that it's, how are we going to start monitoring it in men? Because we do a very lengthy job in monitoring to women. But even then, with the monitoring that we put in place for women, 30% of women don't get their annual exams to be tested. So again, going back to that self-administered, it's going to be in your doctor's office for now, but in like 5 years, if it's at home, would that 30% decrease?
Yeah. Yeah, that's also very interesting. Now shifting a little further down the age group, like more in my age group, I guess, but talking about hormones and how everything is tied to your hormones. Like in the olden days, they used to say, oh, she's hysterical. It must be her mood or it's her hormones or whatever. Menopause is real. This is not a menopause message, but anyways, it is a message out there. But talking about hormones and how females are protected from a hormonal point of view with coronary artery disease. Yeah. But there's a caveat here also with SCAD. So what is SCAD, for example? Because I came across this term and I was reviewing an APS. Actually, there's a great presentation on women and coronary artery disease, but I'll let you pipe up on this one and what it is exactly and why does it affect women. And it's really predominantly hormones.
Yeah, right? And it's spontaneous coronary artery disease because we all know
and
that
it's a
one.
dissection.
It's just a dissection, right? It's
the actual coronary.
And it's predominantly being seen in women in their 40s and 50s, right? Which is about perimenopausal menopausal age. Mm-hmm. It's where the hormones are coming through. But what's very spontaneous is probably the only word you could really use this because it's happening in women who have no history of hypertension, right? High cholesterol, no diabetes, no obesity. So it's like there's no other signs. It's just happening.
Yeah.
And is stress part of the factor? It's stress and hormones that are coming through. Again, in our first podcast series, we talk about how women are like becoming far more financially independent. They're not seeking relationships in the way that they used to. Is maybe this added stress from some of the independence that we're having, societal stress, all these other things, who knows, multiple factors. But I think what's a little bit, for me personally, is a little bit worrisome, and I'm not sure if you share those same feelings, is how are we testing for these hormones? Right. What are the hormones? How do you keep these hormones in balance? Because even when you're just talking as something as what presumably feels simple as cortisol, the impacts of high cortisol on the body are so detrimental with between like lack of sleep, weight gain, tiredness, like even peaking into depression, anxiety.
Like it's a tumbling effect.
It's a domino effect of all these things. And it's like, but there's no real way to treat cortisol other than, what they tell you, like, reduce your stress. Well, it's the stress that's causing you this thing. It's like, that's easier said than done. We all know it.
Easier said than done.
And it's like, low intensity workouts, yoga, Pilates. So like, don't run because that spikes yours, like high intensity spikes. So it's like, but how do you look for something in SCAD? How do you find?
And that's a good point. I mean, next time I go see my physician, I will definitely talk to him about it because it's a topic that I encountered just very recently. And I was surprised that, I'd heard about women and heart disease. I've seen women that have bypass. We've underwritten cases of female that have coronary artery disease. But this particular lady I spoke to, she had this experience and it was a traveler out of country. She was a Canadian and she had this episode in Arizona and she's explaining her journey through the process. And I spoke to her at quite some length because she's, 47-year-old female that had no symptom, perimenopausal, and she found herself in a pretty critical condition and pretty fast. And her symptoms were like odd because as we know, females have smaller coronary arteries. The heart beats faster than a male. And they react differently when they have a cardiac event. They don't have the typical chest pains as we do. And there's a lot of dizziness and nausea and a lot of like soft kind of symptoms that you feel like you're going to pass out or something. And she brought herself to the hospital and they diagnosed her a SCAD and they operated her and they saved her life essentially. And she was stunned and she's, going through and talking about her experience. But for me, it was a real eye opener because I was like, well, if it's all hormone related, then shouldn't we have like a regular hormone panel that we're checking on a regular basis? And like you said, what are those hormones? So I just need to educate myself further on this topic.
I think it's something I think most of us are going to have to educate ourselves on. And, thankfully for, the woman, she recognized those symptoms and took action because how many of us from women have chest pain, we're a little bit tired, whatever.
Nausea.
We just chuck it up to like everyday life, right?
Yeah.
So huge positive that she went to the doctor because I'll be honest, I probably wouldn't.
Yeah, exactly. And she saved her life, And on the same kind of topic for women and social media and body positivity. I know like there's been many podcasts on GLP-1 drugs and should you not, and all the, the pros and the cons of taking such a drug. But, it's really kind of like going down the rabbit hole with this, because you start seeking like body positivity. Why are you doing this? Is it tempting? Heck yeah, it's tempting to want to lose 20 to 30 pounds. As a woman, you're always kind of like on the go, and you're seeking this ideal perfection. For me, I can only speak for myself, but it also leads you to different, anxiety, depression, and it's a slippery slope. And as a female, I can only like, I can't recommend anything, but really do what's good for you and what makes you feel good interiorly, because body positivity carries a lot more weight, pardon the pun, than it should. But
yeah, I think
it is part of our society.
It is a big part of our society, and you've seen that shift. I mean, you can think back to, the 1960s when Twiggy, right?
Yes.
The supermodel. I know I was supposed to say name and I did. Anyway,
But anyways, I think she's no longer part of this world.
But she's no longer. But
I think so. But
there was that heroin chic.
Yes.
That was the fashion that a lot of women became very, very obsessed with losing weight. I mean, just look back. It's always comical when you look back in the 1950s and like the little shake weights.
Yes,
the little
the shakers
that would like jiggle you so much. And by the way, those are back.
They're the
plate things now that you stand on. And it's just like, even those have evolved. It's the same thing ever. But, the one thing that I think, social media brings good and bad into society, nobody's going to disagree with that statement. But when you're looking at weight loss and everything that's out there, you said something that is most profound, and I think we kind of forget it, is you do what's best for you and what's comfortable for you, right?
Yes.
And so if you are thin or if you are not, like what works for you is what works for you.
Yeah, I completely agree. I think we've talked about, like, I think the main issues I wanted to talk today about pregnancy issues, and we talked a little bit about the PAP exams, the HPV, SCAD, and really like the future of women in the medical healthcare space, and how this will all play out eventually for the positive, we hope. And thank you for joining me again today. And that's it.
Yeah, I just want to say thank you for having me. And I absolutely love tackling women's issues, because it's very, very important as we continue to grow as a society from all holistic views that we just need to continue to apply to our underwriting world.
And I will tie you to that this is not your only visit here. So I will tie you back. I will wheel you back in to talk about more topics.
Love it.
Thank you so much.
Thank you.